Hello, welcome to the section of cardiology. This is Dr. Jaitly. In this particular video presentation, I'll be talking to you about how do pacemakers work. Time and again, you've heard that so-and-so person got a pacemaker. What is a pacemaker? Just a basic idea you want to get from this quick video presentation is a pacemaker is a device that's placed externally under the skin in the subcutaneous tissues around your, I call it a infraclavicular fossa, or right below your clavicles, under the skin, and it's done under local anesthesia. It's a small device, almost a third of your, a quarter of your cell phone size these days, and it has a battery which lasts 7 to 10 years. It has a couple of leads, or sometimes only one lead, which is then advanced into so that it can be implanted into the right ventricle. So the route of the lead is, say, superior. Say if you're looking at subclavian vein on the right side, the lead is advanced like this, like I'm showing you in the right panel, and it's advanced into the right atrium, drops into the right atrium, and then it's slid into the right ventricle. This is all done under fluoroscopy. So the operator or the person who is actually placing the pacemaker lead actually sees it where it gets lodged. Then a stimulation is established, and once the stimulation is established, the right ventricle obviously will be the first area of the heart that will be stimulated. Now, which is not something physiological, because normally we know the left ventricle precedes the right ventricular stimulation. But in this case, because it's done through the venous route, obviously it can only be lodged into the right ventricle, because that's where the right side of the heart is connected to the veins. So having said that, once the tip of the lead, if you will, the electrical lead, is nicely lodged and does not get displaced, etc. Because remember, if it is getting displaced constantly because the heart is constantly moving, then it'll lose the point of contact. So it has to be nicely lodged within the trabeculae, if you will, or within the area of the endocardium where it can be nicely positioned, implanted, and then at that point the procedure is completed. Now the impulse is such that it is set as say at a demand inhibition. In other words, if the patient's heart rate itself is over 70, the pacemaker will remain shut, will not stimulate. Now if the heart rate drops below 70, which is more or less always the case that when we implant a pacemaker, then in that case automatically an impulse will travel and stimulate this portion of the right ventricle first. Then the whole stimulus or the impulse will travel throughout the right ventricle first, obviously, and then to the left ventricle, and then the atria above are stimulated as well. So what has happened? Physiologically, we know the left ventricle contracts first, slightly microseconds earlier than the right ventricle. Whereas here, when you have a pacemaker wire lodged in the right ventricle, the right ventricle will contract microseconds earlier than the left ventricle. So what will happen to the septum? The septum will tend to move inwards into the right ventricle, which means it will be dyskinetic for the left ventricle purpose. However, the heart rate will be maintained, and therefore the cardiac output will be maintained. What is cardiac output? We know by definition cardiac output is stroke volume, which is every stroke, the volume that's ejected into the aorta, times the heart rate. That gives you the cardiac output. So pacemaker wire, once that's placed into the right ventricle, will lead you to have a proper heart rate and a fairly reasonable, decent cardiac output in a setting where somebody was requiring this heart rate to be maintained at least 70. Now we have pacemakers where the heart rate can increase depending upon the demand. For instance, if the patient now starts to go up the stairs or runs up a treadmill or goes out to walk or cycle, bicycle, etc., then the heart rate by requirement should be more than 70, obviously, because 70 is at a resting stage. So these days, the pacemakers are so advanced that they can even sense that the metabolic rate or the need or the demand is high for the individual for that particular activity. So automatically it'll adjust to the work ability as well as the activity that the patient is requiring to meet the needs for. Now, as I said, normally if there is a block, for instance, here between the atrioventricular blocks, say the block is somewhere here between 2 and 3. This is the SA node, that's the AV node. If there's a complete heart block, a pacemaker is required. Sometimes it's a very high-grade AV block that occurs, like a Mobitz 2. And if that occurs, we'll refer to those at a different video. But Mobitz 2, for instance, will require a pacemaker being placed. Now, some of these blocks could be permanent, others could be transitory. So you could have temporary pacemaker wires in a setting where there's a transitory block that's noted, or patients will require a permanent pacemaker wiring to be done, a pacemaker insertion to be done, for instances where a permanent block is expected or suspected. Most of the time the blocks are symptomatic, but there are times when they are asymptomatic and they're detected on a Holter or on a telemetry monitoring while the patient is being observed, and at that point it becomes necessary to refer the patient to the cardiologist to have a pacemaker evaluation for insertion, etc. be done. So septal dyskinesia is a given because the septum contracts in participating into the right ventricular contractility more so than the left ventricle. Therefore, the left ventricle wall or the septal wall will be dyskinetic, and that will be reflected even on an EKG like a left bundle branch. So, as I said, it's a very well tolerated procedure. It's done in a matter of 30 to 40 minutes under local anesthesia, and of course done in the operating room under very highly skilled fluoroscopic examination while the wire is being placed in, and batteries are long lasting, and once the lead is placed, then periodically it just requires some interrogation or testing to make sure that there is the current of impedance and current of conductivity, etc. is being maintained. There's not much of an increased resistance, etc. that's developing, and there's no dislodgement of the lead placement. So for those reasons, patient may require regular checkups like once or twice a year, and otherwise it's a life-saving procedure, and I hope you found this interesting. Thank you again, and I look forward to talk to you again. Bye.